Now, wealth is one of the three dimensions of economic status. The other two are income and consumption. Income is very difficult to gather. Consumption is not quite so difficult, but typically takes about an hour for interview. Wealth or household assets takes only 7 or 8 questions. I've heard a total of 7 or 8 questions in this sort of survey. It takes only 4 or 5 minutes, so that's being increasingly used. Now, once you have this information, now let's look at the one on flooring. And you have to combine these in some way into an index. You could just give a score of 1 to each of the different assets if you wanted. But generally, it's done in a somewhat more complicated way called principal components analysis that I won't really bother to understand, to explain rather, or to understand for that matter. And the way it works is if people have an Earth score, they say yes, you give them a score for that question of minus 0.14. If they say no, they get a plus 0.024. And cement and wood and terrazzo, so forth. And you go through all of the questions, and each question has a score. And then you simply add together the scores of different questions to get a total. And you can tell from in the population survey, somebody who has a total score of minus 0.71 in the population as a whole is in the lowest 20% of the individuals. The people in those households constitute the lowest 20% of the individuals in the national sample. If it's between minus 0.71 and minus 0.54, it's in the second lowest 20% of the population survey, and so on. So you can get a reference points, cutoff points for each of the quintiles. Now, once you do that, let's see how we go back. That one. Yeah. Once you do that, you ask the same questions on the investigators ask the same questions as on this survey, this national survey. They put the same questions onto the survey of pharmacy users who they talked to. And they recorded their total scores, household asset scores. And if the asset score of a given household was between minus 0.54 and minus 0.36, they placed them in the middle quintile. If it was above 0.54, they placed them in the top quintile. And then they simply added up the totals in each of the quintiles to see how the distribution was. Now, in this case, you'll see that it was highly pro-rich. People buying subsidized content, the beneficiaries of this program, were overwhelmingly in the top quintile, over 70, almost 75%. Whether only about 7 or 8% were in the 3 or 4 quintiles together on the left. Now let's go to, so from that they were able to get a quick reading of whether that social marketing program was reaching the poor or not, and the answer was no. Now, case study 2, National Immunization Campaign, the drive for Kenya. And here, they collected the economic status of the target population through a household survey, and the economic status of the population served through the same survey. In other words, whereas in Ghana they used different sources of information about the national population, the target population, and the population served, here in Kenya they took a nationwide survey and asked the people, first, have your children been immunized or not? And second, the same household asset questions as in the same, or a similar set to what they did in Ghana. So that way they were able to compare the economic status of the households whose people said, yes, children have been immunized, with all the population that they surveyed. And here, the findings are very different. You'll see it was almost equally spread across population groups. The bottom population group had about 19% of the total. The least poor group had almost 19% of the total, and few of the groups differed from 20%. Each of those, so this is quite an equitable program, unlike Ghana. A third example comes from Bangladesh. In two large districts of the country of about 3 to 4 million people each, and what they did was the patients that governed the health services, and in government health, primary health care clinics. And what they did here was, to begin with, the health team of the district took a survey of communities in the districts themselves, using an asset questionnaire similar to that in Ghana. So what you have, you're comparing the people served not to the national population, as it was in Ghana and Kenya, but rather to the populations in the districts. That was the target population. They figured that whereas the Kenyan national authorities are responsible for covering the population as a whole, the district health authorities in these districts in Bangladesh are responsible only for populations in their communities. So within this baseline, the surveyors then went to some government health, a random sample of government health service center patients at the centers, and an exit interview with the same questionnaire as used in this, to survey the population as a whole. Here's the outcome in one district, Nabinagar district, and you'll see it's generally pro-poor. It's not even, but the poorest, it's not evenly distributed, so you have a spike in the middle, but in generally the trend is downward from left to right. Almost 35% of patients were in the poorest 20% of the population. Only about 10% of recipients, visitors in the clinic were in the least poor. The results from the other district, Shigalaya, were approximately the same. So we have three cases where you got the data in the same format. One was very regressive, the Uganda condoms. The Kenyan immunization was more or less equal across economic groups. And the Bangladesh, the health centers patients were concentrated among the poor elements of the population. Now, none of these programs I've discussed has been a PBF program. And to the best of my knowledge, at least, there are no results available yet for a PBF program that provide results in this format. But there is one PBF program, at least, that's beginning to apply this approach, that's just going, and Alex is very much connected with this. And that is a PBF pilot project in Senegal. So let me spend a few minutes describing how the method that they are using in order to do it there. Now, this will be a description of the method used. The investigators do not yet have results because the project is just beginning. Now, sources of data that they're going to use are about the economic status of the population. It'll be a national demographic and health survey, very similar to same as in Ghana, and about the population, economic status of the population served. It's through a household questionnaire administered as a component of the project verification procedure. The procedure is designed primarily to find out whether people actually got the services that the providers claimed they did, but in the process, the investigators are adding a module, a 4 to 5 minute module of household asset questions, the same as in the National Demographic and Health Survey. Now, the way this is being done is the verification procedure is in 3 stages. First, a random sample of facility is drawn for verification visits, and as I understand it, about 30% of the facilities are to be visited each quarter. And then once the investigators get to each facility, they ask a number of questions about the services provided, and then also draw a random sample of households for interview, 60 to 90 households per facility. And then we go out and interview these people, and as I said, the principal purpose of this interview is to find out whether the providers are honest, that they really provide the services that they said they would. But in the process, they also ask a series of asset questions, the same as in the National DHS survey, that will allow them to compare the assets of the people who are receiving services to the assets of the national population. Now, and here's the asset question, illustrative questions. It's adapted, it's similar to Ghana, but adapted to possessions, land and livestock ownership, how many cultivated hectares, how many cows, how many sheep, etc. Where do you get your drinking water, the type of toilet, the type of roof, the type of flooring, the type of walls, and so on. Now, let's go to close with a presentation on a note on the limitations of the approach, and it's equally important to realize what it will not measure and what its limitations are. And in particular, I think it's more appropriate to describe this approach as a monitoring approach as distinct from an evaluation approach. It's something that allows you to monitor how well your program is reaching the poor over time, but it is not nearly as profound as one might ideally desire for reasons I'll explain. Limitation one is a couple of obvious ones. You're measuring only service coverage. It's not telling you what whether the services are really helping people. So if you're covering the population with lousy services and no impact on health services, it's not going to show up in this presentation. It can measure only the pattern of benefit distribution, not the distribution of costs. So you can show that the better off, for example, are getting much more of the service, but it might be through their taxes, they're paying for a lot more of the services too. What you'll see through the approach I've described here is only that the better off are getting a lot more services, not how much or how little they are paying. And third, and the one that's most prominent in the limitation, and the one that's probably most important to understand, is that this approach can measure only the performance of the PBF program itself, and it cannot compare it with alternatives. And in particular, it cannot tell you whether the PBF program is doing better or worse than the program, the standard program it's replacing, whether before or after or over time. Now let's tell you, or excuse me, not before, after, or in the project areas compared to the other areas. For example, let's just take the ratio of the bottom to top, top, bottom, quintiles. And this is a hypothetical illustration. Suppose the Senegal survey finds that the top quintile is getting, say, 30% of the services, and the bottom quintile is getting the only 10% of the services, so that there's a ratio of 3 to 1. That looks pretty bad. That's pretty inequitable. But suppose that before the introduction of the program in the PBF areas, 3.5, the ratio is 3.5 to 1 rather than 3 to 1. The program is bringing an improvement. So it doesn't look so bad. It's an improvement over the past. It may not be very good, but the past was even worse, the standard approach, whatever that may be. Then let's take a look, compare how it happened in other areas. Let's suppose in other areas that it was the same as in the PBF areas before, but at present it's been an even sharper reduction in the inequality, so it's moved from 3.5 to 2.5. In other words, there's not been there's been an even greater improvement in other areas than there has been in the approach. Maybe the government took on an aggressive facility construction program and staff redeployment programs through other areas, for example, at the same time the PBF was being introduced.